Welcome to the Vital Times podcast series. I am Dr. Ludwig Lin, one of the podcast hosts, and this is a special episode of the CSA podcast to discuss the current state of ketamine use in the United States. Obviously, it's a very current topic, a very controversial one, and we wanted to get a panel of experts within anesthesiology to discuss it. Dr. Rita Agarwal is a clinical professor of anesthesiology at Stanford University. She's a former president and co-founder of the Society for Pediatric Pain Medicine, a member of the American Academy of Pediatrics Committee on Substance Use and Prevention, and a member of AMA Task Force on Substance Use Prevention and Pain Management. Dr. Amber Borucki is an anesthesiologist and pain medicine specialist whose focus is on chronic pain management in children and adolescents and in reducing and managing pain from a chronic condition perspective. Dr. Rakhi Dayal is a clinical professor at the University of California, Irvine. She is double board certified in anesthesiology and pain medicine. She is a pain medicine fellowship program director at UCI and chair of the pain committee at the California Society of Anesthesiologists. I'd like to thank all three panelists for taking the time to do this, and welcome. I am going to start by throwing out a general question, which is, why are we using ketamine? How long has ketamine been around for human patient use? How safe is it? And how do we get to where we are today? Maybe we can start with Rita.
Yes, thank you, Ludwig, and thank you for that lovely introduction. So ketamine was discovered in the 1960s, and it's been used in human medicine as well as veterinary medicine, as many of you may know, since then. It is extremely safe when used appropriately and when carefully monitored. It has a very I think to some degree well-deserved reputation for greater safety than many of the other medications that we have, but obviously not entirely so. I'm a pediatric anesthesiologist as well as pain specialist, and I've been using it for 30 years plus, probably. We've used it in all kinds of situations: sedation, for anesthesia itself, as a supplement to anesthesia in patients, in order to maintain hemodynamic stability, for pain management in the acute setting. I don't do chronic pain, and hopefully Amber can address that more later, or Rakhi can. But we've used it both in the operating room for acute pain management as well as for pain patients who are inpatient with chronic pain. We've used it as a supplement and had really excellent results with it in a lot of patients, not in everyone by any means, but we carefully monitor its use. We carefully monitor for side effects. We watch patients. We know what to expect, what to look for, and how to treat any problems that may occur. So it's an incredibly valuable medication. It does have a large safety profile because it doesn't cause breathing problems in the same way than many of our other anesthetics and sedatives do.
Great. Amber, Rakhi, did you want to add to that?
I think, regarding Dr. Agarwal's last point, its safety profile, we do typically in the pain world, it's been a helpful medication, particularly post-operatively. It can help with large surgeries that patients have, and when we typically turn to it, may be patients who have known breathing disorders where we want to avoid other medications that cause breathing issues, such as opioids, et cetera. So it does have a great safety profile in that area.
Great. Speaking as the non-pain management person in this group of anesthesiologists, I know that I, as a critical care person, really love having ketamine as part of our repertoire of medications. It does not depress the respiratory rate. So, we like to use it for that reason. But at the same time, I've always been warned that it's got severe consequences on our physiology. So it can, for example, increase the heart rate. It could increase somebody's blood pressure. It produces a lot of respiratory secretions. And that one has always been tricky for me. You all are pediatric anesthesiologists, so you could speak to this a lot more. But, it's one of the drugs that we think about for managing general anesthesia and, for example, intubating somebody with asthma because it's a smooth muscle relaxant. So it's supposed to bronchodilate somebody who's having an acute asthma attack. But the increased secretions could actually be a problem. And the increased secretions could itself wind up having respiratory complications. I've also been warned that it carries severe hallucination possibilities. So, that part I've always treated with a lot of respect when contemplating its use. And in terms of the way it's being used now, I feel like a lot of physicians outside of anesthesiology are using it. And that's why we're all talking about it now, because it's being used for treatment of things like depression and maybe even PTSD, in addition to chronic pain. And I wanted to ask all of you about why it is that ketamine is so effective for the treatment of chronic pain and why it's crossed over into management of various psychiatric disorders. Amber, maybe we could have you talk about some of the pain management.
Sure. So ketamine itself is an NMDA receptor antagonist. It inhibits excitatory pathways that we have in the brain and in the spinal cord. All of our, I kind of like start with basic kind of pain, how pain works is, you get your sensation, say in your fingertip, it goes up a nerve into the spine where it gets processed and then up to the brain. And what ketamine does is it can interact in those areas, like in the spine or the brain, to actually inhibit those transmission from, going up to the brain to be processed. It can also, it's been known to kind of reduce some of the chemical signaling that's happening at those levels. So that's where ketamine's helpful for pain. It also is known to assist with some opioid modulated, opioid transmission and opioid receptors as well at those levels. So ketamine works differently, a little bit differently than some of the other medications. And that's why sometimes it's really good to have in your toolbox to add into some other medications that you may be using, particularly after surgery, in the hospital, things like that.
Got it. When you three are utilizing ketamine, what kinds of monitoring do you use for those patients?
Sorry, this is Rita. First of all, I think one of the really important and key points to make is that we use it in different doses for different things. And for something like sedation or as part of an anesthetic, we often will use higher doses. If we're using it for acute or chronic pain management, we typically are using it in much lower doses. And part of that, Ludwig, is to address those things that you talked about: hallucinations, the changes in blood pressure and heart rate, and the secretions that you talked about. A lot of times when we're using it in acute anesthesia situations, we'll use a drying agent like glycopyrrolate or atropine to decrease the secretions to prevent the things that you were saying. In terms of monitoring, at least in the operating room or on the inpatient floors, we're using full monitoring: EKG, blood pressure, respiratory rate monitors.
And I think one more important point is sometimes when we're using it for anesthesia, we'll give what's called a bolus dose. So we give it over a short period of time to take a quicker effect, versus when we use it for pain, we run it as a slow infusion. We're not giving all of this dose over, a minute or 2 minutes. We're giving it over a long period of time in a very slow infusion. So when we're giving ketamine for pain, for anesthesia, we're giving it in different manners. And that requires all these different types of monitoring.
To be safe, because we're all about being safe. Go ahead.
I do want to add here, like as an anesthetic, we've used it for over 60 years. And because of those dose ranges and the art that goes into using it in different forms, sometimes we need to protect the airway, because although it has like safety features, it is used in a way where it could be very, very dangerous for patients. So based on the situation, we need to make sure the patient's airway is protected, or we're taking precautions so there are not enough secretions and we're using it in doses that are safe for the patient.
Right. Rakhi, let me ask you a little bit more about this because you deal a lot with pain management. I'm sure that all three of you have patients who are on various medications because it's difficult to manage these conditions. So, what happens when somebody is on ketamine but is also using other medications for their pain management or for concurrent psychiatric um, conditions? Are there things that people really need to watch out for, and what are the potential downfalls?
A good question. So, a lot of the patients that we use these medications on, ketamine on, could be on a lot of pain medications, which are working on different receptors, or psychiatric medications, which are also covering different receptors. That means there's a risk of effects in these patients. So, we do a rigorous process in assessing the medications they are on, the medical comorbidities that they have, the health conditions they have, the heart disease, um, liver disease, kidney disease, and if they have certain neurological conditions such as seizures, we really want to be careful with the medication. We don't want to give it because it can increase their risk of having adverse effects. So it takes a lot of safety parameters, and several teams do actually have even pharmacists involved in assessing and seeing like ICU teams, like to see what all the patient is on and ensure interactions are safe for the patient.
That makes a lot of sense. It takes a whole village to take care of these patients, it sounds like. Can any of you address particular classes of medications that uh, would have very strong interactions with ketamine? Any offhand that you can share with
Well,
us?
you have to be careful. Definitely, again, going back to my acute pain situations and acute settings, when administering it with other opioids or other sedatives like benzodiazepines, like Valium, Ativan, lorazepam, because even though, one of the things that has made ketamine so popular is the fact that it doesn't affect respiratory rate and respiratory function as much as some of these other drugs, it still can cause respiratory depression. And when you combine it with other medications that do that, it can absolutely um, have more of an additive or even synergistic effect and cause more respiratory problems. So you really have to be cautious if you're using that. The other group of medications that you have to be careful about is any of the medications that can cause, or drugs that can cause a sympathetic response, medications or drugs that can increase heart rate and blood pressure, such as cocaine, is one that springs to mind. And that's not one that we would be prescribing normally, but I mean, if a patient it has, you know, has an addictive personality or is using other substances, it's something to be careful about and ask about, because cocaine will also increase heart rate and blood pressure. And you throw in another drug such as ketamine on top of that, and that can definitely also increase it even more to a point where it's quite dangerous.
Yes, I could totally see that.
And then,
And like, oh,
Ludwig,
sorry, go ahead. Mhm.
ketamine is metabolized by, as Rocky brought up, the liver. And so there are different drugs that can alter ketamine's metabolism within the liver. So we have to be very careful. Even something as simple as St. John's wort or grapefruit can alter its metabolism. So we need to be careful when we're taking these medications, looking at what else we're taking, even what we're things like what we're eating, like grapefruit, things like that, that can alter its metabolism.
Thank you for pointing that out. It just goes to demonstrate how necessary it is for patients on ketamine to really have good medical care and to be willing to be transparent about everything that they're taking, which, as Rita just pointed out, sometimes is hard for people with polysubstance use. They might not want to divulge, and that just makes it even harder to keep those patients as safe as possible. Yeah, Rita's point was really good. It made me think, people who are taking opiates and benzodiazepines, which is kind of inevitable in these chronic pain situations. If you take enough of these things, they're going to become unconscious. And at that point, it almost doesn't matter if they still have a respiratory rate, right? Like if you're breathing, but for example, you have a lot of upper airway obstruction, or you can't get yourself out of a dangerous situation while you're passed out, bad consequences can happen. Well, this makes me want to follow up with some questions for you guys about ways to keep these patients safe. So I think that's kind of what we're all thinking about in light of, current events. What are the current safety features, regulations, guardrails that are in place to keep patients from overdosing, for example? What are the regulations that are in place to make sure that we do monitor these patients appropriately and have the appropriate follow-up? If I could have all three of you pitch in and give us your thoughts, that'd be great. We'll start with Rakhi.
Yeah.
Okay. So yeah, we do have a lot of safety guidelines in place. Every hospital follows, and all practitioners, we follow national guidelines. For pain management, we have guidelines established from our national societies, which is based on scientific literature for several decades. So we know the doses in which we can keep the patients safe based on a detailed review. For monitoring, we have hospital policies ensuring close monitoring of the patient. Their vital signs are being assessed all the time. There's always a provider who can rescue their airway if some issue happens to the patient. We have medications in our order sets, which ensures we are checking for side effects in a good frequency and pre-treating them or treating them if they have certain side effects from the medications. Everything is done under physician supervision to ensure safety of the patient, and I think that's paramount.
What about outpatients? What are the safety regulations in place to check on those patients?
So for pain management, ketamine has been used in outpatient clinics, where a patient may come to the clinic. They may receive ketamine in a similar manner to how they would in the hospital, so through an infusion. And again, in this situation, in the clinics, there would be monitoring, as Rakhi just brought up, similar monitoring, similar standards, similar abilities to have rescue equipment if something were to happen, and physician oversight. So that's kind of how an outpatient management of ketamine that would be given through a clinic would look. There has been growth of use of ketamine in a different manner, however, that has kind of been over the past couple of years, which is use of things such as compounded ketamine, use through oral or sublingual formulations, where there's been prescribing of this. And this, in this situation, actually, the FDA in 2022 issued a concerning report and a risk alert regarding this, due to potential risks associated with this. And did advise the public to be careful, and that there was an increased risk of use of this.
And Ludwig, as far as I know, the answer to your question is, I don't think there are a lot of guidelines for outpatient use. Part of it is that the growth of the industry is so dramatic, and I just don't think regulating agents have really had, and national societies who try to oftentimes are ahead of regulating agents in trying to issue guidelines, have really had a chance to catch up with it. I mean, we're all hearing stories now of patients who can order ketamine IV through the mail and have it delivered through different companies, and I don't even understand how they're administering it to themselves. Well, unfortunately, I kind of do, but it's just beyond the pale to think about how this is being done. And right now, there is no there are no guardrails in the way it's being practiced. We have this humongous growth of virtual companies, virtual quote unquote physicians, because many of them are not physicians. It's not physicians who are necessarily, there are definitely physicians involved as well, but anyone with a license to prescribe um, is prescribing these drugs and sending them to patients, unsuspecting patients who really don't know how potentially dangerous this drug can be. They get sold on the safety and the great safety record for all of these years that ketamine has been around, and they know it's also a club drug that kids take and young adults take, and they don't generally die from it. But unfortunately, now we're beginning to see that, right? Because as it continues to expand in its use, we're going to see more. We're going to see this happen more often. Hopefully, the FDA and other regulating organizations will catch up and start issuing some more stringent guidelines regarding its use in the outpatient world. But right now, those don't exist.
If the three of you were volunteered as experts in drawing up some guidelines for these outpatients, what are some of the boundaries that you would like to see installed in terms of the way ketamine is being used as outpatients?
No IV.
There was some up there. No IV. Why is that? Tell us
No,
more.
so no IV in a situation where there's nobody trained to help monitor. I think the chances of things, um, potential complications, even by the best meaning, you know, most caring people that you have with you, it is too easy to give too much medication, whether intentional or unintentional. And we're not even talking about patients who have issues with addiction, because clearly, that is a whole separate group of patients. We're talking about patients who are really just there to get relief from their pain or their depression or their anxiety or their PTSD or whatever other symptoms that they have. It's so easy to say, well, you know, if 2 milligrams of this works, or if X amount works, maybe 2X or 4X or 5X is going to be better. No one's here. Why don't I just give myself a little more and see what happens? I think the risk of really bad things happening with the IV use of unmonitored ketamine in an outpatient, and I don't mean outpatient in a clinic. I think that's a very different situation. I'm thinking more about the home deliveries of ketamine vials and people having access to that. I think that is inherently incredibly dangerous. Um, it's really like sending, methamphetamine through the mail and saying, hey, we know a little of this works really well for your ADHD symptoms or for your depression or for, and it does. It works great for ADHD and for depression in a lot of patients. So just use the right amount and don't use too much. And we're not really going to check up on you. So
Right.
I would say no IV in that home infusion market. I think oral, again, Amber referred to some of the things with the FDA, and those have to be compounded in pharmacies. And so there's a whole layer of things that go in there. I do think we have to figure out ways to make it safe. I think the intranasal is maybe okay, but I think IV is really asking for trouble.
And then remember that kind of the current oral compound medications are not FDA approved. They are made by compounding pharmacies. And I think the alerts that the FDA has put out have said a lot of these times they're concerned because then they don't come with all the FDA labeling of safety effects, concerns, et cetera. So you're not getting a package insert, you're not getting all that information, you're not getting all this education. What the report even goes in further saying that, an oral they have reports of oral ketamine doses that they found in patients that were alerted to them that were double the dose of anesthetic doses, like blood levels that were much higher than we'd expect even when we give it through IV for anesthesia. So I think this is an unregulated area with, dosing and how this is being provided and safety and instructions. So I think that obviously is an important area to address with
Gosh,
regulations.
we need to at least have truth in what is being compounded. That part actually is very worrisome, but it's not surprising. I mean, there are other medications being compounded that turn out to be either fake or yes, are not being measured in terms of its true dosage. So thank you for pointing that out. That would be a big deal. Rakhi, what are some of the things that you feel are current gray areas in all of this, and what makes you worry about the way ketamine's use is, growing in the United States?
So the number of ketamine clinics in United States has increased exponentially in the last decade. And that is interesting. Like, what is it stemming from? It's this stemming from management of pain in some cases, and we have national guidelines for that. It is also stemming for treatment of mood disorders, depression, and suicidal ideation. I think they're very important diseases. And more recently, with COVID, we have seen an exponential increase in depression, suicidal ideation. So we should do what we can. And I am not an expert on the literature, but there is some evidence of its use for mood disorders and, of course, for suicide ideation. But we are experts as anesthesiologists for use of the medication for over 6 decades. So my goal here in terms of safety regulations is to provide an option where we can use our expertise in tailoring the medication for appropriate use for these new indications that are coming. I feel the need for patients is a lot for therapeutic modalities because there's a lack of pharmaceutical options for patients to treat certain disorders, especially mood disorders. And from what I read, patients are expressing unfavorable responses for the side effects they experience from certain medications. And that's why they're favoring this as a treatment option. We have in the last several years seen unfortunate mortalities from the use of this medication. So, as much as it has a place for its use, I think physician led use under the collaboration of an anesthesiologist to establish national guidelines. Um, and more scientific research. If we don't know enough about the doses now, we do have ground level research in terms of knowing what safe use is for pain management. These are unprotected airways. We know doses in which patients can keep their airways safe, be safe, and use this medication safely. I don't know if that's the correct use for mood disorders or mental disorders, but more collaborative scientific research, data driven, outcome driven guidelines in safe monitored setting is what I would like to see for these patients.
Such a great point. I think everybody has the best intentions, but there are so many different ways for these drugs to be used in a way that is inappropriate. And if people don't have the necessary education, the knowledge, and accurate medical histories for a patient, how could we, possibly do that? So collaboration, education, discussion. But then I think a lot of what Amber has said about the appropriate regulation of the way the medications are manufactured, are being delivered, that is a much bigger question. I guess the problem though is for something like ketamine, inappropriate manufacturing practices, inappropriate delivery, they carry lethal consequences. So
But
that's why
that's
we're
where you
here discussing this.
Right. I mean, that's where you would hope that the FDA would get involved and try to standardize. I mean, I can't imagine. I don't actually know what it takes to manufacture these ketamine troches, I think they call them, right? Um, but I can't imagine that the FDA couldn't get involved with trying to set some standards as to how they're manufactured and how, make sure that there's some quality control and the doses are similar from one troche to the next troche, because we've definitely seen patients who've been on it long term or relatively long term, and have done well, when everything else has failed for both. And we've assumed a lot of times in pain that it's a combination of both helping with their pain and potentially helping with some underlying depression. But
Right.
that's where I would like to see, if the FDA does get involved with this, which hopefully they will, that they would also look at these alternative um, ways of delivering the substance so that
Right.
it can be consistent.
Right. Well, it sounds like the story isn't quite finished yet with all of this. I want to bring this conversation to a conclusion, but before that, I want to make sure that I asked all three of you, is there anything else that we haven't touched on today that you feel our audience should definitely go away with from the conversation?
The only other thing I would add is that there are also long-term consequences to the use of long-term ketamine, such as it can cause bladder and urinary issues when it's used in a long-term manner. For example, we try to limit when we're using it for our either our acute pain patients or our patients with chronic pain who are inpatient, who are in the hospital. We try to limit it to about 7 days because there's just not much literature on its utility past that. It seems to stop being as effective after that period of time, and we do worry about bladder issues. There's other complications too, but that one's a pretty serious one.
Thank you. Amber, Rakhi, any additional thoughts?
No, I just loved what Rocky had to say. I wholeheartedly agree. Top down, systemic, wide, looking into this and looking at every aspect of how we can make this safer. If there are findings that this is helpful for mental health care, well, let's involve all of the appropriate people and all the appropriate regulating bodies to make this safe then. From everything from manufacturing down to supervision to monitoring, and the appropriate place the medication should be given. Every single one of those things I feel like needs to be looked at. So I loved your answer, Rocky.
Thank
This is
you.
great. I feel like we need to go back to why we're all here as physicians. We are here to treat people for their pain, for their other issues, but we also need to do that with respect and to make sure that they stay safe. And that sounds like it's going to require a lot of collaboration amongst the different disciplines trying to tackle these various medical issues. So, yeah, like I said, maybe this story is continuing, and it's a call to action for us to get involved. But I also think this has been a great opportunity to try to educate our listeners about this. So, thank you all for being here today to discuss this. And this is Dr. Ludwig Lin for the California Society of Anesthesiologists. Thank you so much.